Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
We tend to cover everything cheap, which is basically the generic medicines and everything else. And when patients require more expensive drugs, brand name drugs or biologics and so on and so forth, the coverage becomes less and less. That means they're exposed to those prices more and more, which makes absolutely no sense because it goes against the premise of what insurance should be.
Welcome back to Healthcare Matters, the podcast that pulls back the curtain to help you make sense of complex healthcare economics and policy issues. As always, I'm joined by my partner in crime, Dr. Robert Popovian, joining us from our nation's capital. He's a pharmacist, economist, and the Chief Science Policy Officer at the Global Healthy Living Foundation.
And across the country in Seattle, Washington, he's Connor Mertens, patient advocate and community outreach manager at the Global Healthy Living Foundation, and the individual who has been tasked with finding the next starting quarterback for the Seattle Seahawks.
I think I got a better shot bringing down drug prices than finding a good quarterback for us at this point. But as we get into season 2 of this podcast, we've been covering even more ground on what you need to know about healthcare economics and policies.
But before we get started, as always, we want to be sure for you to take a listen to the other great podcasts on the GHLF Podcast Network.
And right now, Talking Head Pain with Joe Coe is a must listen. As a migraine patient and advocate himself, Joe truly brings to light what living with migraine is really all about. And you can find all these podcasts at ghlf.org/listen. All right, let's take a look at one of the comments from our listeners. Laura says that Healthcare Matters Part 1 and Part 2 of non-medical switching made it easy to focus and learn about the topic. They do a good job defining complex topics.
We appreciate the comment, Laura. And, this is why we do this podcast, is to help patients understand and humanize the entire policy and economics issues that we continuously face as either patients, healthcare providers, or as consumers of the healthcare system. Thank you, Laura, and please keep the comments coming.
We invite you, too, to go to Apple Podcasts and write a positive review and leave an honest 5-star rating. And wherever you're listening, Apple, Spotify, or the rest, click that subscribe button so you'll never miss an episode. Well, Robert, we were going to talk about international versus domestic U.S. pricing of drugs, but while we were talking off air with our producer, they brought up something that I think is very important and something that a lot of folks deal with in their day-to-day and actually is very related to drug pricing. What did our producer Ted tell us, Robert?
Well, Ted was very interesting because we were talking about doing a segment, as you said, on international versus domestic drug prices, and we will do this in the future episode. But he brought up the conundrum that his parents are in. Mary, his mother, basically pays $200 every month for a single pill to be taken for a heart disease that she has. And Ted was very genuinely concerned and was asking us specifically, why are patients paying so much out of pocket, especially patients who are on Medicare and fixed income and cannot afford these pills? And these are life-saving medicines that they need to take on a regular basis.
Well, let's get into it. I don't want to ask too broad of a question, Robert, but why are they paying so much for medications on a fixed income and supposedly supposed to be giving concessions?
There are several reasons. Let's start with benefit design, which is very unique in the Medicare program. And in this case, it forces patients at some part of their plan year to be in a donut hole. And oftentimes that donut hole requires them to pay the full cost of the medicine. So first and foremost, it's a benefit design issue, which is very unique to Medicare that you oftentimes don't see in insurance plans that are provided through employers.
I mean, everyone knows kind of the Medicare Part A, B, C. What do those all have to do with this?
Medicare Part A really provides hospital services. They cover the hospital costs incurred by the Medicare patient. Part B is designed to provide outpatient services. Like this is when a patient will visit their physician or their physician assistant or nurse practitioner, and that's what's covered through Part B. Part D Medicare is the prescription drug coverage, and it's the newest part of Medicare that was implemented in the mid-2000s. And this is the part that really is very different than what you see in typical insurance design models, where patients go in and out of what we call a deductible phase, where they are fully exposed to the cost of the medicine. And frankly, Connor, this issue has to be addressed. It's a bipartisan supported initiative to address this issue. Unfortunately, it was added as part of the Build Back Better initiative that President Biden and the Democrats introduced. And because that legislation had so many other issues, it did not go through the Senate, although it did pass the House. And what we need to do is revisit this in the Senate level and make sure that we fix the benefit design, which is very unique to the Medicare benefit.
Another thing that I think is interesting about Medicare and Medicaid is what is the relationship that they have with copay cards or patient assistance programs?
Patient assistance programs provided by the biopharmaceutical industry are forbidden to be provided to any kind of Medicare or Medicaid recipient, which interestingly makes very little sense because, if anything, those are the patients that are the higher consumers of medicines that are sicker and generally need the patient assistance programs rather than the employer population that gets their health insurance through the employers or they buy it individually in the marketplace. That is forbidden by the federal government because of an anti-kickback statute. And this is something that Congress needs to address regarding patient assistance program that is not available to these patients.
So the discussion we're kind of having right now is federally speaking, right? Are there different rules and regulations at the state level that can be kind of modeled after?
Not really, because most of the program is geared towards through CMS on the federal level. So Medicare is definitely a federal program. Medicaid is a state program, but is really governed through Center for Medicare and Medicaid Services, CMS. And really, those rules are the ones that prohibit these patient assistance programs that are provided by biopharmaceutical industry to go directly to the patient. But Connor, it goes beyond that. When you start peeling the onion on how coverage for pharmaceuticals is versus hospital services or physician services, you notice that we are woefully wrong in the way we've designed benefits in the biopharmaceutical space and comparatively to the hospital services or physician services. The best way to put it in a layman's term is that in the pharmaceutical space regarding benefit design is that we tend to cover everything cheap, which is basically the generic medicines and everything else. And when patients require more expensive drugs, brand name drugs or biologics and so on and so forth, the coverage becomes less and less. That means they're exposed to those prices more and more, which makes absolutely no sense because it goes against the premise of what insurance should be. Insurance is typically to protect patients against therapies or interventions or needs that are less frequent. And instead, what we've done in the biopharmaceutical space is that we cover inexpensive generics, which most people take, but we expose patients when it comes down to brand name medicines or biologics or anything that is very expensive.
So, Robert, I think that kind of starts to explain why Mary's paying so much out of pocket.
Exactly. Most likely, like you and I, Connor, when we take a generic medicine and we go through our insurance companies, we pay very little. And then when we need these brand name medicines, which very few people do, because again, only 10% of the prescriptions filled in the retail space, in the pharmacy space, are brand name medicines, patients are fully exposed to the cost of those drugs.
Robert, at this point, it kind of seems like those that are most in need are having to pay the most. And I think that those who are paying the most price in more than one way are folks living with chronic disease and the elder population. What can we do to see this change? Is there anything on the books? Are we working on any federal legislation in the moment?
Not at the moment. We tried, and you're absolutely right. People like Mary are exposed to higher prices for a variety of reasons. This benefit design that we discussed, but we also have an issue with regards to these brand name medicines that the biopharmaceuticals put out in the market. They generally go through a very convoluted and opaque contracting mechanism with these pharmacy benefit management companies and insurers. What the biopharmaceutical companies do is that they provide significant concessions in form of rebates, discounts, fees, and everything else that goes to these pharmacy benefit management companies and insurers. And unfortunately, none of that trickles back to the consumer at the point of sale. That means Mary, when she shows up at the pharmacy and requires this brand name medicine, which is priced, let's say, at a retail price of about $10,000, the reality is that the pharmacy benefit management company and the insurer is probably paying around $4,000, maybe $3,000 for that drug. So the $7,000 savings over a year period, let's say the total of 1 year, doesn't get passed back to Mary when she shows up at the pharmacy counter to pay for her medicine.
And Robert, you know that as patient advocates, we're always trying to elevate the voices of those who aren't heard. So why is it that there's not a lot of progress being made in this space? Who's advocating for this population that's at risk and spending so much on their healthcare?
Unfortunately, not many. And this is a consequence of the system that we have currently, which is seniors, our most vulnerable patient population, don't really have a constituency out there lobbying on their behalf. And the one organization, unfortunately, which is AARP, that is supposed to be looking out for seniors and lobbying on their behalf, is really conflicted because they have a partnership with one of the 3 large PBMs, pharmacy benefit management companies, to promote their senior drug program. So in essence, AARP is conflicted out of this because they are essentially a pharmacy benefit management company on their own because they make a great deal of revenue from maintaining the current model, which is peddled through insurers and PBMs.
Well, thanks for breaking that down for us, Robert. And I know at the end of each episode, we like to give you the last word, but I think this time you should give the last word to Mary. What can we tell Mary to put her mind at ease or offer a little hope for some change and a little more affordable life-saving medication?
Well, Mary and her son, Ted, can become advocates for change, first and foremost. And that's the hope, because people know what the problems are. Basically, that we have a backwards benefit design in Medicare. We have a Medicare benefit design that is not truly an insurance design, and it creates loopholes that force patients into significant out-of-pocket costs. Also, none of these concessions and everything else that has been negotiated on her behalf gets passed back to them. So we know the problems, Mary. We know the problems, Ted. What you need to become is become advocates and educate yourself and know that as we have exposed these problems, the only way we're going to change these things is through legislation. And guess what? Seniors vote, and your vote counts. So you need to show up to the ballot box and support individuals, and specifically individuals that are aligned with policies that will support and protect seniors.
Make your voice heard. Don't be quiet.
Exactly.
That's great advice, Robert. Thanks for listening to Healthcare Matters, a podcast that pulls back the curtain to help you make sense of complex healthcare economics and policy issues. As always, we invite you to go to Apple Podcasts and leave one of those honest 5-star ratings and write a positive review while you're there. That'll help people like you find people like us. And wherever you're listening, Apple, Spotify, or the rest, click that subscribe button so you'll never miss an episode. He's Dr. Robert Popovian.
And he's Connor Mertens, and I want to provide my own thanks to Mary and for Ted to bring their story to us for us to be able to discuss. We will see you all next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.